Hello and good day. Thank you very much for the opportunity today to make some comments. I want to acknowledge Learn and CoStar and thank you for the opportunity to present today. This topic of digital care in physical therapy is a very interesting intersection of professional worlds for me. I've been a physical therapist for over 30 years and currently serve as the Chief Digital Strategy Officer for Duke Health. So I'm excited to be here today, listening to the comments and looking forward to the question and answer period. From the disclaimer file, I have none to offer. I have no conflicts with any companies or industry segments being discussed today for what that's worth. And I've prepared these remarks in hopes of speaking to categories of tools and concepts. No intent here to speak to any specific vendors or products, and there is no implied endorsement. So what I hope to generate today actually is some discussion and some thought, both in today's question and answer series and following as you consider how to advance the use of these tools in your practice. I hope you find these comments useful. The topic I've been asked to address is quite broad and can be very wide-ranging conversation. And I'm going to take this hopefully from sort of the art of the possible angle. You can then pick and choose the areas for which you consider and want to consider further development based on your own patient population and based on your level of comfort or discomfort with the topic. The discussion today should really start with an acknowledgement of the APTA's position on digital care and digital tools within physical therapy. The infographic to the right comes from their webpage, and I think it's an interesting one. It addresses some of the things that we'll talk about today. The advantages of digital care include access and convenience, and even perhaps some advancement in quality of care and new growth opportunities for the profession and the professional. There are things that need to be addressed still. The topic is new and the evidence is burgeoning, but it seems to be positively trending, and I think it's something for us to be very carefully observing. Note on the bottom, it says the association supports and guides the augmentation of physical therapy with digital health services to safely and efficiently expand the scope of work. They also published a formal position paper in November of 2022, the link on the left of the screen, in which they ask vendors who are building physical therapy specific telehealth tools to take a pledge to ensure that the care is provided by licensed physical therapists and licensed physical therapist assistants in support of the profession. In that paper, they say, and I quote, "Over time, these tools can enable clinicians to expand their reach, improve access to their services, and deliver critical data on patient progress and outcomes to ultimately drive improvements in care." I happen to agree with that with just one caveat. I think I would take out the over time. The time is now. I would argue that these tools are available now, and the opportunity that they describe as a future one is available now. The opportunity exists today. We'll start with just a comment about things to ponder. I don't suggest that this is an exhaustive list, but as you contemplate employing digital tools in your practice, there's plenty of things to think about. It starts with privacy. Remember that you must consider privacy, data security, and patient consent in some instances. Understand that some of these tools will require the consent of the patient to use. If you believe, as I do, that certain reminders based on location or activity or other types of alerts are useful, you'll need to know where the person is in order to be able to apply the appropriate alert. To do so, you need to know where the patient is, and you need the consent of the patient to track their location or help them to be able to figure out how to set up these haptics and alerts on their own. Recognize also that many third-party applications that a patient may use and that you may even recommend are not governed by HIPAA rules. So you have to be thoughtful very much about with whom you share protected health information. Understand when BAAs should be entered and what protections they bring. Understand also the very simple fact that text messages, SMS messages, are unencrypted which means not secured and can be intercepted. SMS messages require that we allow the patient to opt out of receiving them. Next is data validity. As if you're using remote tools to capture data in support of your clinical decisions, you should be comfortable with the quality of the data that they bring. You should be comfortable that you understand what the limitations of the tools are, and that you're using data with which you're comfortable to make clinical decisions to support your patient. Also, understand, or I believe that digital tools can and should be used to both complement and supplement care that's provided in other ways. The image represents complementary and supplementary angles. Recognize that care might be delivered to a patient in person, supplemented by virtual care. And also, the patient might see you for a musculoskeletal condition and have other chronic conditions for which they're using mobile applications or chronic disease management applications and such. All of these things should be complementary and woven into the whole patient care. The design of these tools should fit with the 360-degree view of the person, not just the condition being treated. Make certain that these tools are woven together in such a way that the whole patient is remembered. Access to care, depending on your care area, you might participate in multidisciplinary rounds, for instance. Digital tools can facilitate this, and regardless of the care setting that you might be in. Imagine consulting with a colleague, bringing in a remote or distant colleague into an evaluation or to a consult setting. Imagine a school setting where you can bring in a colleague from the clinic. Imagine a long-term or extended care facility, post-acute facility, where there are multiple rounds and we can bring in providers from outside. One of the earliest adopters of telehealth at our institution, for instance, was a neurologist who specializes in treating ALS. And he would provide the opportunity to consult with his patients and manage care of his patients remotely, especially given the late-stage patients that had respiratory distress and support needs and significant transportation burdens and such. And so he was one of our earliest and most successful users of telehealth and continues to do so today. The digital divide, I think, is real and must be contemplated. But if thoughtfully designed and applied, digital tools can help close this gap in equity. I believe it's real, but shrinking, this digital divide. And it must be contemplated, and analog solutions should be continued to be available as an essential part of the tool belt. Access and adoption to technology cannot be necessarily assumed, but should be assured as these technologies are applied. Adoption is a lot of things. It means, are patients aware of the tools and the opportunities? Are they intimidated by the technology and therefore might be hesitant to use it or less receptive to the capabilities? Are they willing users? The spectrum is here. The wide spectrum is here. Consider the patients and their comfort level. All those things, I think, also apply to us as professionals as well. If we aren't comfortable with the technology, we will be less capable or less effective in deploying it. There are cultural, sociodemographic, geographic barriers to consider as well. And all this has to be part of the mix. That said, the data are compelling. There is ubiquitous access to technology, and this ubiquitous access affords tremendous opportunity. The data suggests there are nearly 7 billion smartphone users in the world. That's 86% of the world's population. And in the United States, it's 307 million smartphone users, 85% of the population. Certainly, that doesn't mean that everyone is equal. There are certainly still some very early smartphones in use, and people who use the smartphone as a text and telephone only, not necessarily adopting other applications or technologies. But all data are suggesting that patients are preferring these tools, even expecting them, even making choice of their provider based on the availability of these tools. We're considering this in our own organization today too, ensuring that we meet the patients where they are across the entire technology spectrum. Let's go to some basics. The first basic is a patient portal. If you are an institutional practitioner, if you work for a health system, you likely have access to a portal. And that means that the technology burden is covered for you. It should include identity management, making certain that you're communicating with the patient that you believe you are. Data security and privacy should be contemplated. But I think the portal is a really key tool and affords an opportunity to be able to communicate with the patients safely and securely, to create a portal experience that is individualized or personalized to that patient's individual care needs and care journey, and is a remarkable tool to be able to use. If, however, you're in an independent practice, the equation is entirely different and brings different issues for you to contemplate. There's expense to building a portal, there's technical debt to maintain it. And if the patients are required to have a portal for their physician, a portal for their hospital, and a portal for their physical therapist, there's the opportunity or the risk of what we would consider to be application fatigue. There's the opportunity for remote physical or physiologic or remote patient monitoring. These tools can be used in the clinic, as well as have the patient use these tools in their home independently to support or supplement or complement, as we said earlier, the care that they receive in your physical location. Biofeedback and qualitative exercise feedback, tracking biometrics. There's near-term utility of ambient monitoring and other active monitoring to help not only manage conditions that are currently being experienced, but also anticipate degradations or care problems. As a physical therapist, we know for many years that gait speed or decrease in gait speed can be a predictor of falls. And so these things can be measured by some of these remote monitoring devices. And the article that's listed under the picture comes from Frontiers in Psychiatry. It describes a digital cognitive screener, and it was published last July as a proof of concept study investigating reliability, validity, and feasibility of a digital cognitive screener among community-dwelling adults in screening for dementia. These tools, these data can be captured now, and the potential for near-term uses and unique uses of these data is truly remarkable. I love the term nudge. If you haven't read the book Nudge by Richard Thaler and Cass Sunstein, I would recommend it, because much of what we do in physical therapy and even healthcare writ large is attempting to change behavior of our patients. Nudges can come in multiple forms. They can be device alerts on the telephone that you have in your pocket, third-party applications providing alerts or messages, outbound text messages from you, the provider. Recognize that there's many different ways to send these alerts, and they have various response rates and open rates. Text messages are by and large opened very quickly and at a very high rate, whereas emails are not necessarily opened nearly as often and do not have as reliable of a call to action response. So these things should be considered. Haptics or device alerts driven by location, time of day, or activity or lack thereof, or other input from your smartwatch or your fitness tracker or an application or the portal itself. AI or artificial intelligence powered alerts related to time sequence of recovery or chronology, accomplishment of milestones or participation in the program. All these things are very handy to be able to nudge a patient into the direction that you want to go. Telehealth is table stakes. In physical therapy, there's all kinds of things to consider. There's third-party applications to support PT-specific telehealth, recognizing the pledge that the APTA is requesting from these vendors. There are reimbursement issues for all of us in healthcare, including in physical therapy. So be aware of both the regulatory and the legislative response here and the payer actions that are following, and our opportunity to advocate for the profession and the patients we serve. There's an example in our own institution of remote cardiac rehab that was started during the pandemic, where instead of bringing patients in for cardiac rehab for in-person care, we did this remotely, and we've learned a ton in the 3 years since, and we're finding actually increased higher participation rates, lower recidivism, lower readmission rates as a result of remote cardiac rehab, for example. Mobile applications brings tons of things there to consider. There are exercise programs, instructions, logging progress, et cetera, biofeedback for patients. Caution, again, the term that we used earlier about application fatigue. In 2020, there were 350,000 health-related mobile applications on the market. and 90,000 of them were released in 2020. So if you extrapolate that out in 18 months since, and if the release has remained flat, which is not a safe assumption, that means you can add another 225 or so thousand to that number. Many applications get loaded, and the durability of them is very poor. So people will have dozens maybe of applications on their phone and use very few of them. The Journal of American Medical Informatics Association published this piece in 2018, and they studied applications designed for use in chronic condition management, diabetes, respiratory disease, hypertension, et cetera. And they noticed that they were designed to either stop a negative behavior or continue a positive one. Again, that's behavioral change and nudges that we referred to earlier. They found better outcomes when the applications included a combination of passive and interactive features. And if passive only, they became less effective. An interactive feature includes prompts, but also an ability to upload information, biometric information, requiring some action and some participation or adoption from the patient. Interactive ones also include active treatment plans, personalized health goals, two-way communication abilities, and then also clinical decision support for the patient and shared decision-making support. Passive features include one-way communication, passive alerts, in other words, and passive reminders. Recognize also that the patient may have other applications we mentioned earlier, self-management or wellness applications. All of this should be woven together again in a very complementary way as described earlier. Next up, or actually probably already here, AR, VR, augmented reality or virtual reality. There's this, the definition of augmented reality is an interactive experience that enhances the real world with computer-generated perceptual information. In this article published in the Journal of Serious Games, I had no idea there was such a journal before I was preparing for these remarks. They published this piece called Augmented Reality in Physical Therapy, a Systemic Review and Meta-Analysis. They posit that that there's improved orientation of exercise toward a stated objective when using augmented reality. There's an improved engagement in the program, that the biofeedback and feedback to the physical therapist about the quality of the exercise performance, and then also that same feedback to the patient is valuable, and that the early evidence suggests that it's favorable but remains incomplete. I yearn for a day when education and materials can be offered to a patient at a literacy and numeracy level that is specific to that individual patient. At our institution, our radiologists have developed a tool that translates the radiology read from the provider into human readable form, and it's been remarkably well received. It is, however, a standard. It's not individualized in any way, but I do believe that artificial intelligence and machine learning and better understanding of our patient's individual numeracy and literacy offers an ability to educate the patient at a level that they understand completely. I think that's essential. And then artificial intelligence, machine learning, and deep learning. These are sort of catchy phrases and almost jargony, but they're important to contemplate. Machine learning is inside of artificial intelligence. So all machine learning is artificial intelligence, but not all artificial intelligence is machine learning. And machine learning is a subfield of AI, gives computers the ability to learn without being programmed. In other words, it learns, these models learn as they are run. It's really a fascinating opportunity. No conversation on this topic would be complete without just a nod towards GPT and large language models. My clinical experience was mostly in managing spine care, back pains, neck pains, radiculopathies, and such. And so I went into the OpenAI page and put in a simple prompt, and I said, how do I treat low back pain? Imagine that this is essential for us to understand because our patients can do this today. And this was generated in about 3 seconds. It took me a minute to do this. Open a browser, log into my account, type in that prompt, and this was given to me immediately. And if you look at it pretty quickly, the result's not terrible. It says rest. I might modify the specifics of the rest and to say avoid provoking activities. It says use of ibuprofen or acetaminophen. We as professionals probably would want to understand other medications that are in place before recommending any other over-the-counters. It suggests activity and exercise, continue to be active. It suggests application of hot or cold. I'm not terribly offended by that. It does suggest down here in number 5 to consult a physical therapist who can teach exercises to do these things and more. It offers acupuncture and massage. Nothing grossly offensive here, but I think I mention it here because a patient may very, very well bring something like this to you for your contemplation or for your reaction. Missing here are any red flags. So I said, okay, let's take the next prompt and say, is low back pain dangerous? Because I would hope a patient might wonder about these things, although that's not assured. Is low back pain dangerous? It's in most cases not. In most cases will resolve in conservative treatment with rest and exercise. In some cases, however, there's an underlying medical condition, severe pain that does not change with rest. It's unrelenting. Numbness, tingling, or other neurologic symptoms, bowel or bladder symptoms, fevers, chills, unexplained weight loss. That's a fairly decent red flag list that I was taught 35 years ago. And if you're experiencing anything, go to seek medical care. The point is, this is algorithmic. Our decisions are algorithmic. GPTs and large language models cannot be trusted to do these things independently yet, but the pace at which these things are expanding and improving is remarkable. And I don't believe we yet know how we will be disrupted by this technology, but I'm certain we will be. So I think the takeaway for me is be creative, be very thoughtful, imagine how to use these tools, act ethically, act safely, act equitably, and be informed, because there are opportunities that are present today and they're changing very rapidly. Thank you very much. I look forward to the opportunity to discuss further in the Q&A.